Depending on your time zone, good morning, good afternoon, good evening. Welcome to the third session in the ATS and Union joint webinar series, Elimination of TB, Why Not Now? My name is Naidoo. I'm a pediatrician based out of Cape Town, also a TB advocate. I'm joined by my co-chair, Nguyen and Nguyen from the University of Sydney. I really would like to thank the American Thoracic Society and the Union for their collaboration on today's webinar, as well as our distinguished panel of speakers for providing their insight into such a devastating disease such as TB elimination. Before we begin, just a few brief notes and some reminders. Everybody here is muted due to the large number of registrants. And if you have a question, we just encourage you to place it on the chat function, and we'll sift through them towards the later Q&A session. Please note that the webinar is being recorded and it will be made available to all registrants. And the archive webinar will also be present on the ATS website. So please feel free to share that to your colleagues. The aim of our webinar today, which is the third in a series of 4 on the ATS, is to discuss the role of active case finding on the road to elimination of tuberculosis. With that, I turn over to Tion, and thank you so much for our speakers, and she can introduce them as they come along.
Thank you, Uvistra. Hi, everyone. This webinar will feature 4 speakers addressing a wide breadth of TB elimination topics. Our first presentation, what have we learned from surveillance surveys regarding finding the missing cases and what next, will come from Dr. Yogan Pillay. Dr. Pillay is the South Africa Country Director at the Clinton Health Access Initiative. Next, we will hear about mass screening and active case finding from Dr. Morten Ruhwald. Dr. Ruhwald is the head of tuberculosis at the Foundation for Innovative New Diagnostics. After that, Dr. Max O'Donnell will present on how susceptibility testing supports current and future treatment. Dr. O'Donnell is an associate professor of medicine and epidemiology at Columbia University. And lastly, we will hear from Dr. Annika Hesling about finding missing cases in children. Dr. Hesling is professor and director of the Pediatric TB Research Program at the Desmond Tutu TB Center at Stellenbosch University. Following all presentations, we will have a discussion among presenters. Again, please submit any questions you may have through the chat function.
I am Yogan Pillay from the Clinton Health Access Initiative in South Africa, and I'd like to thank the Society and the Union for inviting me to participate in this webinar. And my topic is, what have we learned from surveillance surveys regarding finding the missing cases and what next? I have no conflicts to declare. Let's start with TB surveillance and what it is. According to WHO, surveillance data has been globally recognized as a fundamental data source for assessing both the burden of disease as well as epitrends of TB. And according to the ECDC, surveillance is a crucial component in the control and elimination of TB. And it's fairly clear that we need the data in order to track progress towards elimination. It's also useful to look at the strengths of the TB control programs, as well as identify remaining challenges that need to be addressed. Let's start with how WHO estimates TB incidence and mortality. 4 main methods are used, according to Glasgow and others: results from TB prevalence surveys, notifications in high-income countries and adjusted by a standard factor to account for underreporting and underdiagnosis, thirdly, national inventory surveys, and fourthly, case notification data combined with expert opinion about case detection gaps. Mortality in their estimates are obtained from national vital registration systems of mortality surveys in quite a few countries, and amongst 21 of them based on estimates published by the Institute of Health Metrics and evaluation. So you can see it's a combination of a number of data sources that gives us the World Health Organization's annual estimates of both incidence and mortality. Now, what are TB surveys? TB surveys, according to Colvin and Castro, provide the most accurate measure of the burden of disease and data for monitoring trends over time. It's without such surveys, they suggest, countries typically depend on the World Health Organization modeling that's done annually to estimate prevalence and incidence, and on program reviews to understand performance and gaps in programs. In countries where the private sector provides a significant amount of TB care, for example, India and Nigeria, amongst others, prevalence surveys can help to get the true burden of TB. According to Pillay, prevalence surveys are also used to know where people seek care, both in the informal sector, private sector, as well as the public sector, and whether they have symptoms or not when diagnosed with TB. Swaminathan, the Chief Scientific Officer of the World Health Organization, argues that the critical to prevalence surveys is really the issue of the quality of these surveys. So such surveys need to be of very high standard, both in the way in which they're designed as well as the conduct of them. Let's move on to TB case notification. And this slide is from the World Health Organization, which both shows in the table how TB notifications are defined and the disaggregation, as well as how the rate is determined. In countries where most, if not all, new TB cases are diagnosed and registered, the number of notified TB cases, therefore, provides a good proxy for TB incidence. However, this is not the case in many countries where underreporting of detected cases and underdiagnosis results in serious gaps between the number of notified cases and really the true TB incidence. In South Africa, TB is one of the notifiable medical conditions, and the National Institute for Communicable Diseases has a notification system that is both electronic as well as paper-based for those that cannot use the electronic system. And all doctors and nurses in both public and private sectors are expected to report, and failure to report a notifiable medical condition in South Africa is a criminal offense. This slide is an overview of the reporting system in the electronic format from the National Institute of Communicable Disease, and it really tries to focus on the importance of prevention, detection, and reporting and responding to any of the notifiable medical conditions. And I guess the importance of this slide lies at the bottom of the slide, which focuses on the surveillance system acquiring information from national at all levels of the system to detect and respond to public health threats in order to prevent disease outbreaks, estimate the burden of priority diseases and identify populations at risk, monitor place, person, and time trends in monitoring priority diseases, and direct public health interventions and to inform public policy decisions. And I think in these four lies the importance of reporting against these national medical conditions. This slide shows the data that's publicly available on the website of the National Institute of Communicable Diseases in South Africa on microbiologically confirmed pulmonary TB. And it shows the trends by incidence, by age and gender, as well as by the 9 provinces in the country. Moving on to prevalence surveys, this is data from South Africa's first ever TB prevalence survey that was reported on in 2018. And what this shows is that prevalence is higher in males than females, and that the lowest prevalence was found in 15 to 24-year-olds, with amongst the highest prevalence in the 65 plus age group. In this slide, we show that symptomatic patients did not seek care in fairly high numbers. The highest was amongst 15 to 24-year-olds at 82.3%. Now, these are people with symptoms who have not sought care, And amongst the 24 to 34-year-olds, the percentage that did not seek care amongst participants in the survey was close to 80%, with males at just over 70%. The lowest, even though overall the percentages are still high, was amongst those that were 65 years and older, as well as those that were already tested HIV positive at 54.8% and 56.4% respectively. There were many reasons for not seeking care. An astounding 60% with symptoms said they intended to seek care, with a further almost 27% regarding their symptoms as not severe enough to seek care. When patients did seek care, or at least participants did seek care, the bulk of them, almost 90%, sought care at community clinics, with 8% seeking care in the private sector and 4.5% at public hospitals. So the bulk of our patients in South Africa, at least, seek care in public clinics at the primary healthcare level. And this means that both surveillance as well as routinely collected data and the quality of care in our public clinics needs to be significantly high to eliminate TB over time. So what are some additional findings from the survey, and what are their similarities with other countries? The overall prevalence in South Africa was measured, estimated to be 737 per 100,000, with a confidence interval ranging from 580 to 890, with prevalence, as I said previously, significantly higher in men than women. Now, if you look at WHO estimates for South Africa over the last decade or so, you will see that in 2012, the estimate was 1,000 per 100,000, 2019, 520 per 100,000, and in 2020, it's 615 per 100,000. So this again shows the value of prevalence surveys. With the wide variation in prevalence estimates from the WHO over the decade. With respect to other countries, similar prevalence survey findings were in Kenya and Vietnam with respect to the difference between men and women. Within Vietnam, men having a prevalence rate of 4 times higher than women. The proportion of survey participants in South Africa who reported no symptoms but had TB disease on a chest X-ray was almost 60%, which clearly means that reliance on symptoms screening alone was and is inadequate. As noted before, 15 to 24-year-olds had relatively low prevalence at 423 per 100,000, but the significant issue found in the prevalence survey was that this age group also had the largest prevalence to notification gap at almost 2.91. Similar was found in India, Indonesia, Philippines, and Pakistan, where this particular cohort, the 15 to 24-year-olds, represented 5% of total TB incidence, but 20% of TB transmission. Here are some lessons from Nigeria published last year from their attempt at implementing TB surveillance in a number of provinces, states in Nigeria. Surveillance intervention was focused on 3 activities: hospital-based surveillance, community-based surveillance, as well as health systems data strengthening. The hypothesis being that missing TB patients were being treated in private hospitals in Nigeria, operating largely outside the national TB program, and that a significant proportion of patients were undiagnosed in communities or diagnosed but not notified. The intervention, interestingly enough, leveraged on Nigeria's polio eradication surveillance structure and processes, which was largely successful. As well as annual immunization campaigns, as well as community informants were used to cascade TB surveillance to community level to reach areas underserved by traditional TB services. One of the things they did find was inadequate training on disease surveillance affects the effectiveness of the surveillance system, as does the absence of feedback to healthcare workers in peripheral facilities. So here are some examples from Colvin and Castro on the uses of surveillance data. Firstly, general updates to national strategic plans, goals, targets, and priorities were used for global fund applications to seek additional funding for the TB program. Secondly, focus on newly identified population groups or geographic areas at higher risk. Third, an increase in emphasis on activities related to active case finding and case detection. That's the missing cases. Fourth, increased focus on the private sector and its role in TB detection and treatment. Next is the modification to screening criteria and algorithms, especially in response to identification of cases who were symptom screen negative, as well as smear negative, culture positive cases. Next would be the expansion of the use of gene expert, and we've seen this now in many countries. And then finally, increased use of digital X-rays, including, I might add, portable handheld devices, as well as the use of artificial intelligence. Next, we come to what prevalence surveys don't tell us. Now, in the 2010 Global TB Report, the WHO highlights 5 risk factors for TB, these being HIV positive, undernutrition, smoking, especially in men, alcohol use disorders, and diabetes. Now, of these risk factors, the most prevalent surveys collect data on HIV positive status and a few on tobacco use. The table on the right of the slide from Colvin and Castro gives some examples by various risk factors, which countries collect data on these risk factors. And you can see there the sparsity of risk factors collected by most countries in their prevalence surveys reflected in this slide. Most surveys focus on young people 15 plus and not younger children, so we have very little data on the prevalence and incidence as well as mortality in younger children. The need to focus on socio-demographic factors, including nutritional status, is fairly obvious from the risk factors, and of course the need to collect data on diabetes. And as you can see from the figure on the right of this slide, very few countries collect data on diabetes. It's just Myanmar and Indonesia in recent times. Secondly, these prevalence surveys, of course, do not tell us the extent of the catastrophic costs, and these are not determined. And what one needs is national patient cost surveys to supplement the data in these TB prevalence surveys. And key, of course, is the quality of the data. If the yield is low and the quality of the data collection is poor, of course, there will be many gaps in what these surveys tell us. Now, one of the things that has concerned many of us over the years is the cost of these prevalence surveys, especially if they are to be conducted fairly frequently, such as every 5 years. China has recently started implementing a new TB surveillance system in selected prefectures. And this is a slide from Yang and others who suggest that a pilot system was designed based on local information systems and using unique identification and focusing on data interoperability. The improvements in the piloted system included automatic data extraction instead of manual entry, as well as additional statistical functions that assisted clinical service provision. The major challenges in the implementation and scale-up found in this pilot were the licensing issue of the software being used and the diversity of existing infrastructure that hinder the potential of scale-up, as well as the cost of the system. The pilot, however, did accumulate experiences for the rollout of the National Health Information System regarding technical solutions of reforming current information systems, as well as effective training approaches for the developers as well as the users of the new system. And I guess this pilot shows 2 things. One is that it is important to implement new surveillance systems as the technology improves, but there are challenges that one can anticipate, and obviously one has to anticipate them early enough in order to mitigate these challenges. Finally, some concluding remarks. Firstly, establishing and strengthening routine information system and conducting surveys are indeed expensive for many low and middle income countries. representativity and the quality of the data, especially in these surveys, including the prevalence surveys, are very important. Using routinely collected data improves its quality, and we've seen this across many disease programs. Use of data to improve program performance is as important as collecting the data. So using the data from whatever source for program performance improvements are critical. And partly, returning data to health workers for local use is more likely to get the analysis as well as the data used. And this was shown by colleagues in Nigeria, for example. Information, both data and analysis, shared with communities and other stakeholders, including the private sector, given that in many countries the private sector is an important provider of services, in ways they find acceptable, improves uptake of services. And then finally, there are many lessons from the COVID-19 pandemic that we can use to improve surveillance in the TB space. This includes agility in responding, community mobilization, a bottom-up approach, community participation included, use of mHealth solutions, and in South Africa we've used a number of such solutions for COVID. We are now planning to use them or expanding some of their uses for TB, including what we've called TB Check, where people and general community members can use an app to check their TB symptom status. I'd like to thank you for your attention, and again to thank both the Society and the Union for their invitation to participate in today's webinar. Thank you very much.
Thank you. My name is Morten Ruhwald. I'm head of the TB program at FCPaed in Geneva. I'll talk about tools to allow for mass screening and active case finding. I'll set the scene by putting this in the context of COVID, which really has changed the game in diagnostics. We have seen massive investments in research and development, in manufacturing capacity, also in lower middle income countries. We've seen an upgrade and expansion of the diagnostic install base, and we've seen an integrated response to COVID from clinics and labs working together in a de-siloed way. There's been a revolution in digital health and an uptake of digital tools, and basically a global upgrade of diagnostic literacy. So I think with that in mind, we need to rethink how we are approaching TB. So we can hopefully replace sputum-based diagnostics. We can hopefully bring tests and samplings closer to the community with new tools. We hopefully can de-silo the TB response moving forward in a much more integrated way. And we can make every diagnostic connected. And that's what we're working on at FCPaed. I will talk about various classes of diagnostics and how they fit into this mass screening theme for today. And I'll start with radiology and artificial intelligence. So chest X-rays remains the most sensitive tool we have to detect long TB. And we now have computer-aided detection softwares, or CADs, that can interpret the digital software, the image, and does provide an abnormality score. So here you take a chest X-ray image, has to be an AP chest X-ray digital. You put it through an artificial intelligence algorithm, either locally on a computer or in the cloud, and then it outputs an abnormality score. And some of these softwares also give an overlay of with a heat map, so you can see what kind of abnormality they have responded to. We have 10 manufacturers who are in late stage development with products, and together with Stop TB, we made a homepage called AI for Health to monitor the field, and it's really a fast-moving space. These softwares were recently recommended by WHO for policy to replace humans, and you can see here in a study from Bangladesh, and from Dhaka and Bangladesh, it's an urban setting, where they have screened almost 24,000 symptomatic adults. And the performance of the softwares are here expressed as an RC curve. They also had board-certified Bangladeshi readers to look at these images and scored them either as any abnormality, probably TB, or highly suggestive of TB. And you can see the softwares do seem to perform with a superior specificity at these individual sensitivity points. Where this really becomes powerful is when you combine it with ultra-portable digital X-ray systems. For instance, this one from Aspen in the US. So here the chest X-ray or the X-ray generator weighs about 3 kilos, comes with an ultra-sensitive screen and an iPad-like device to look at the image after it's been obtained. But there are several other manufacturers with similar products. You can then have your software either on the cloud or here as a local piece of as an external computer you plug into your computer. And then you put your X-ray generator on a simple tripod like this, and if you are standing 2 meters away from this instrument, you are free from radiation exposure. And you can see you can really take it into peripheral settings for screening in communities. And there are several kinds of additional tools that makes this a comprehensive response. You can in this collaboration between Fujifilm, Cure, Modbio, and Toyota, they put it on as sort of a TB screening lab that both does the screening with the chest X-ray, but also the confirmatory testing with the Modbio tool. And you can have solar panels for charging, etc. We put together a report on this space to sort of give a status of where we are now, and it's an interesting read for those of you who are interested. You can download it for free at the FIND webpage. I'm just showing you here a small movie on how an event-based screening can happen with one of these mobile systems. So they do a simple questionnaire here, and then they set up this person for screening here. They take the image here, and it automatically goes to one computer. They press a button, and it goes to the other computer for interpretation with the software, and that takes about 1 minute. So clearly, very high throughput, and the best of these teams can do several hundreds in a day. Other fast movers in the field of AI for TB is point-of-care ultrasound, digital stethoscopes, and even AI-enabled cough apps. Really has been explored for COVID from multiple sides, and really fast-moving field. And I'm interested to see how this is gonna pan out. The use case needs to be developed, of course. So moving into non-sputum based diagnostics to replace sputum to go into the communities here. And I'll start by talking about LAM, which probably is the most likely target for an antigen RDT in tuberculosis. So LAM is a molecule on the outside of the membrane of the TB bacteria, and it's detected in both the lung, in sputum, in blood, and also in urine. And it's concentrated in the urine, which is sort of where the detection is normally done. And for the last 10 years, we have had the ALEA-LAM, and now there is in late stage development the FUJI-LAM SILVAM TB test. And here, when you compare these two, and this is a study that pulls together results from 5 studies, all on frozen samples, that compare these two tests head to head. 1,600 patients. You can see the sensitivity of the FUJI-LAM is about twice that of the ALEA-LAM at a retained specificity. When you stratify it by CD4 cell count, the sensitivity in the low CD4 cell strata here is about 90%, where we would have 56% from ALEA-LAM. In the high CD4 cell count, it's about 44% here, with only 11% from the ALEA-LAM. So FUJI clearly is superior to detect TB in people living with HIV, and we hope to see this moving for WHO policy review sometime next year. The million-dollar question is, of course, how does these tests perform in HIV uninfected? We know the Elimination is quite useless with a sensitivity of only around 11%. The Fujilam does seem to perform better, but there's few studies yet. So this one study suggests around sensitivity of around 53%, but we need more data. And clearly where we need to go is to have third generation LAM tests that are ultra sensitive, so about 5 times more lower analytical sensitivity than the Fujilam. We can obtain that with improved reagents or with some kind of pre-analytical sample preparation, either with filtration or with bead-based concentration. Or we can have innovative assay designs where you have readers and other approaches to amplify the signal. And with that, we believe that we can get a TB detection test for all patients, irrespective of HIV status. COVID also really has led to a revolution in sampling methods, and a swab is not what a swab used to be. So a lot of new materials and approaches have seen the dawn of day with COVID. And it does seem that TB detection can be pushed up to around 70–80% sensitivity if you scrape the back of the tongue. And that's a really interesting space that's being pursued by many academics and actually also some of the manufacturers at the moment. If we can do the same with saliva, spit-based testing, gargle remains to be shown, but at least for COVID, we've learned a lot. Stool is promising for TB detection in children, and there recently was a WHO review of data, and we don't know the outcome of that yet. At FIND, we're interested in aerosols for TB detection. So you put in these absorptive strips with polyvinyl alcohol inside face masks, or you filter the exhaled breath with some kind of sampling tool, and then you can then do a molecular assay afterwards for TB detection. This works well for COVID. And it does seem to work well for TB as well. Whether it's strong enough as a TB detection tool or it is some kind of TB transmission tool remains to be determined. But when we look at what has just happened for COVID, it seems that we still haven't come to the bottom of this yet. So I'm just giving you an example of a recent publication in Nature Biotechnology. So here they have the same approach with a face mask, but inside the face mask they have this collection zone, and then they have a CRISPR-based TB test. So you push water after you've worn it for about 90 minutes. You push this water reservoir through, and you hydrolyze the different reagents that are in this test here. So you have a lysis of the COVID virus, then you have an amplification zone, then you have your CRISPR detection zone, and then it comes out on an RDT, a rapid diagnostic test, sort of a lateral flow assay here, where you would then have a test readout, and you can see the lateral flow here is on the side of this face mask. So whether we can do stuff like this for TB would be fantastic, but clearly, we would not have expected to see this kind of tool emerging for any aerosolized-based pathogen a couple of years back. So let's see where we can push TB detection with aerosols. So for assays that can detect TBs, these are molecular tools. We have FCPaed, ModBio. We know these well. But we also will soon see the launch of the SD Biosensor Standard M platform as a strong competitor to the FCPaed platform. They do actually offer a broader drug resistance panel at a higher speed and a much more modular approach. It seems quite promising from SD Biosensor. We haven't seen any performance data yet. Pioneer are also planning a larger instrument with a broader drug susceptibility panel here. And of course, we have the LAMP-based assays still. We also have the high throughput systems, the centralized molecular diagnostics for that are, the backbone of HIV and COVID in many countries, and hepatitis C as well. But there are TB detection assays here, and I think once we move back into a more normalized response, I think we should leverage as much of these instruments for TB programs as well. So they do offer upfront INH testing, which is great for INH monoresistance. And as said, you can have these multi-disease testing at the same time. Sensitivity is similar to expert, and resistance detection is similar to line probe assays, and they are WHO policy reviewed and approved. So how can we go about mass screening in the communities? So we can have our healthcare volunteers and healthcare workers. They are the backbone of this. We can combine it with swabs or face masks, and we can combine it with strong sample transport systems. And then we can have our high throughput analysis much more as a hub and spoke compared to what we're currently doing with the Cepheid system. And when we combine that with some of the digital tools that have been developed for COVID, we can then send the results digitally back to our healthcare workers or the patient themselves, and also to the surveillance systems for the monitoring. But when you look at what's happened for COVID, this seems a little bit unambitious. So this is a system that, or a workflow that was put together by Quantigen, Steripac, Corteva, LGC, and the Gates Foundation. And here they use dry swab for nasal swabbing, for self-sampling as well. You put these into automated swab handling systems, and then you put them on really high throughput PCR systems like this one from Nexar that can do up to 100,000 samples per day. They use assay tape instead of plates, and here you can have almost 6,000 samples per run. So here the assay tape goes in and comes out like a reel here. And because there's a barcode on the sample all the way to the assay here, you have end-to-end link, so you make sure that this automated workflow really does not misplaces a sample. So we can look at these things that have been available for COVID, and we can be creative. We can use our Uber Eats, and we can use drones and whatever we need to get these samples into really, really high throughput centers and make this happen, just as this collaboration is making high throughput COVID testing happening in a couple of places in the US at the moment. I think we also need to look at TB infection as a comprehensive response. And there are a lot of new tools here as well. We used to have the quantiferin and tuberculin skin test, but now we actually have more than 15 new tools entering the market here. We have automated high throughput for the QIAGEN system. We have antigen-based, rapid diagnostic test-based IGRAs, like this one from SD Biosense or Bodytech. And we now also have specific skin tests, so tests that do not cross-react with BCG, that are being made available for global launch by the Serum Institute of India, Shifei in China, and the well-known Generium Diaskin test in the Russian-speaking region. And I think we also need to look at surveillance as well, and look at COVID and see what we can change here. So when you start scraping into where the data actually comes from the Global TB report, well, much of it is paper-based data collection. COVID has been a digital disease from day one, and I do believe we can be inspired by that and go into a future where we have real-time dashboards for TB as well. And there's several permutations of this, but I don't think I have time to go into these details now. So I think I'll stop here by just saying that COVID has brought a new reality in diagnostics, And I do think we have a growing pipeline of connected TB diagnostics and innovative sampling strategies that can enable high throughput screening and mass screening of TB. But there are, of course, major gaps that remain, and it's critical to make use of what we have now so the missing millions become the detected millions. And let's reimagine triage and screening approaches with all of these new fancy tools. And with this, I'd like to say thanks to the team at FIND, and of course all the funders who are making our work happen. Thank you very much.
Good morning. My name is Max O'Donnell from Columbia University Medical Center, and I'm speaking to you today about how drug susceptibility testing supports current and future TB treatment. My declared conflicts of interest include speakers' fees through Otsuka, funding from Gilead and Amazon for COVID-19 therapeutic trials, which was paid directly to Columbia University. So, how does drug susceptibility testing form the keystone with adherent support for the prevention of amplification of MTB drug resistance on treatment? So by way of background, drug resistance arises in populations of bacteria spontaneously through stochastic mutations. In this case, isoniazid resistance, which may be selected for, maybe in the setting of inadequate drug susceptibility testing, by isoniazid monotherapy for isoniazid resistance. And then within that isoniazid resistant population, rifampicin resistance may occur spontaneously, which again, we may be selected for through inadequate treatment, for example, with isoniazid and rifampin, to lead to isoniazid rifampicin resistant MTB or multi-drug resistant tuberculosis. This isn't simply a conceptual problem, but a problem that's been with us since the very inception of the TB therapeutic field. So this is a very interesting article from the British Medical Journal from 1948, showing a TB treatment trial, the first with streptomycin monotherapy. And what it shows in this figure is the line, the initial X shows the date of the last sensitive culture, and the subsequent X on the line shows the date of the first resistant culture. So what you can see is in this group of 100 patients with TB who are treated with streptomycin monotherapy, each and every one of them developed streptomycin-resistant tuberculosis over time. And this isn't just a problem of 70 years ago, but it's a problem that is defining the TB field today. So this is a Kaplan-Meier curve showing the tremendous mortality with the Tugela Ferry outbreak in rural South Africa. But what I want to draw your attention to is that these are patients who have what we subsequently defined as XDR TB, extensively drug-resistant tuberculosis, but there were patients being treated for MDR TB who did not have second-line drug susceptibility testing performed because it was felt in South Africa that since second-line drugs were not routinely used, that this was a sort of inappropriate use of resources to do second-line DST because they surely wouldn't have resistance against these second-line agents. Well, in fact, in this outbreak, they did, and it turns out that the real epidemiology of drug-resistant TB in KwaZulu-Natal, South Africa, is that there's a highly drug-resistant isolate spreading sort of unchecked among HIV-infected and immunocompromised populations. So really pointing out the real risks for the population for doing inadequate drug susceptibility testing in tuberculosis. And this is a problem not just for South Africa, but globally. So this is an article from Lancet Infectious Disease 2019, showing the concordance of drug susceptibility pattern and treatment for drug-resistant and drug-susceptible TB. So essentially what you're seeing in panel C, without stepping through it entirely, is that both under and over treatment of tuberculosis with therapeutics can result in increased mortality. And very specifically in that last column, you see patients with drug-resistant tuberculosis who are inadequately treated experience very high mortality, unsurprisingly. So what then is our current armamentarium for drug susceptibility testing? Well, we have standard agar culture drug susceptibility testing. We have liquid culture, or minimum growth inhibitory tubes to sort of more sensitively and rapidly detect drug resistance. We use a nested real-time PCR mechanism, GeneXpert or GeneXpert Ultra, to detect TB as well as rifampicin resistance. And then a new cartridge, GeneXpert XDR, which detects resistance also to isoniazid, fluoroquinolones, as well as the aminoglycosides. And then in certain high resource settings, such as New York State, where I live, there's whole genome sequencing that can be performed as well. And I'll speak a little bit more about that. So whole genome sequencing is a very exciting and promising way of sort of characterizing drug resistance mutations, of individualizing treatment based on susceptibility from genetically derived susceptibility, and it is able to use a very granular, detailed examination of the genome to construct transmission and transmission networks and identify nosocomial outbreaks. So this is work published in PLOS Medicine with Kira Cohen as the first author, looking at using whole genome sequencing to dissect the evolution of extensively drug-resistant tuberculosis in KwaZulu-Natal, South Africa, over 4 decades. So this is looking at the Tugela Ferry outbreak and sort of trying to use whole genome sequencing as well as some assumptions about rates of mutation and the introduction of antibiotics to construct a analysis over time to see how this clone arose. And in fact, whole genome sequencing sort of shows us that this very resistant isolate did not arise all at once, but was selected for over decades by the serial introduction and inadequate drug susceptibility testing for different agents for tuberculosis. So since I'm speaking to a group of TB control officers, scientists, and other experienced folks, we know that we're in a very exciting time for TB therapeutics. So there have been more new agents introduced in the last 10 years than there have been in the previous 40 years. And we have whole new definitions and whole new regimens available for us for the treatment of drug-resistant tuberculosis. And that is extremely exciting. And I would also say it's potentially problematic in the sense that our drug susceptibility testing methods and capabilities have not kept up with the therapeutics. So this is just a very quick review that I'm not going to go through in detail of the new regimens for MDR-TB, including the standard short course regimen for MDR-TB, the extended course regimen, and now very excitingly, the 6-month BPAL or NICS-TB regimen. And what you'll see is that all of these regimens are linchpinned around bedaquiline and other new agents such as linezolid, delamanid, pretomanid. And this is just from the New England Journal showing the NICS-TB initial trial, which was an uncontrolled trial of about 100 patients, looking at and showing a very high cure and completion rate, almost 90% at 48 weeks. And sort of follow-up data has come out suggesting that this result is durable through 24 months. The problem with this is even in this very first treatment trial, almost like in the BMJ, we already saw resistance at baseline and resistance emerging to bedaquiline. And when we look across cohorts at bedaquiline treatment cohorts, we find, in fact, that there is resistance at baseline. So this is work done by a group of students working with me at Columbia. So this is very much work in progress, not published, but constructing a forest plot looking at rates of resistance in bedaquiline treatment cohorts to bedaquiline. And you can see from this that somewhere between 5 and 10% is the average percentage of bedaquiline resistance in these cohorts. And in fact, that's what we're seeing in our studies in South Africa. So this is from European Respiratory Journal. Camus Nimmo is the first author. And this is a table showing 10 patients with bedaquiline resistance The orange are resistance at baseline. The white are emergence during treatment. And this, without going into it in detail, is resistance defined genotypically by mutations in the RV0678 gene. And what you see is the MICs of the baseline resistance are low and mostly at the cut point for formal resistance bedaquiline. But the MICs for the patients who developed emergent resistance during treatment, as you can see, are generally speaking at, but primarily well above the cut point for formal phenotypic resistance. So this is actually quite a big and emerging problem. And sort of unsurprisingly, in the same study, this is a Kaplan-Meier curve showing much worse survival for patients with emerging bedaquiline resistance. And that brings us to sort of where we are currently. We're using the standard drug susceptibility test results, as I sort of showed you. Many of them are phenotypic, and there are limitations to these existing phenotypic approaches, including time. So these are slow techniques. Most of them depend on MTB growth characteristics. As we all know, the organism grows very slowly. They're poorly reproducible, including MIC testing. So you have to do this at least in triplicate, and there'll be some variation in terms of what you see in terms of the minimum inhibitory concentration to the antibiotic. There's the need for laboratory capacity, including BSL-3 labs, to handle these drug-resistant strains, which don't exist in low and middle income countries. And then there's occupational health and lab health considerations. There are also, unfortunately, limitations to genotypic approaches. The genetic basis of TB drug resistance may be complex, incompletely understood, and poorly predictive of clinical response. Whole genomic sequencing can be expensive, $85 to $450 per genome, depending on where you're doing it. And then there's the requirement to sequence MTB from MTB culture, which increases time and cost. And it also does not detect phenotypic resistance, for example, bacterial persistence or destroyed lungs harboring bacteria that are difficult to treat. The other problem with genotypic resistance is it may be sort of all over the place. So this is mutations in the RV0678 gene, which can confer resistance to bedaquiline. And what you sort of see with this figure is that some of the resistance conferred may be quite low level and equivalent to wild type, while some of the resistance conferred by mutations in this gene might be quite high level. So those are current gaps in MDR-TB genotypic drug susceptibility testing. And these are gaps, unfortunately, for all of these new agents that we're so excited about. So bedaquiline, linezolid, protominid, and dolaminid. The genotypic drug susceptibility is poorly understood, for example, in protominid and dolaminid, incompletely characterized, for example, in bedaquiline, protominid, and dolaminid, complex, for example, in linezolid, protominid, and dolaminid, and poorly predictive of clinical outcome, frankly, in all of them. So it may be based on those limitations that a phenotypic assay, even though, as I said, there are problems there as well, might be the right answer to identify and prevent resistance in novel regimens. So we have some possible approaches. Right now, the approach that's most in advance is the cryptic plate. So this is a 96-well plate with lyophilized antibiotic in each well at pre-specified concentrations. And what you do is simply pipette the liquid culture into each of these wells. And over time, you can sort of see, if there's growth in the different wells at the specific concentrations, allowing you to determine the MIC cut point or the resistance cut point for each of these antibiotics. And so the problem with this plate, although it's being validated and it's quite useful, is that it does take time. So this takes about 21 days on average. Sort of more exciting, but less tested work includes phage-based work. For example, this is a paper published by Paris Jane and colleagues in the Journal of Bacteriology using a new luciferase mycobacteriophage for detection of MTB drug resistance. And essentially, this is a powerful genetic reporter that integrates using a virus with the bacteria and produces a fluorescent signal in the presence of viable bacteria. And so it allows for a much more rapid 3-day turnaround time detection of drug resistance. And what you see in this slide, I'm sorry for the small text, is that against these all these new drugs of interest, that it's very powerful at detecting susceptibility, but this has not yet been tested in large clinical trials. So in conclusion, I would say that there are significant risks for both individuals as well as global TB control with empiric treatment for drug susceptibility testing. That new drug susceptibility testing methods are needed for these novel MDR-TB regimens, and that while genotypic methods are promising and will likely have a role, it's also likely that new phenotypic methods are needed to bridge the critical drug susceptibility testing gap. Thank you.
Hello, everyone, and thank you for the opportunity to talk to you about finding the missing TB cases in children. So what is the global burden of TB in children? It's thought that about 12% of all TB cases globally are in children below the age of 15 years of age. And WHO thinks about 1.19 million children below the age of 15 develop TB every year. WHO also requires the stratification of TB cases in children by 0 to 4 versus 5 to 14. And this is important based on the type of disease and the ability to diagnose this disease by age group. Several of the high burden countries really contribute significantly to this burden of estimated pediatric TB cases. But it's important to note that these are also the settings where resources are the most limited and where diagnostic strategy should really take this into consideration. So what is the gap between actual cases estimated versus reported? The gap is dramatic, with more than 50% of children not actually being reported that are estimated, and this gap being more pronounced in the youngest children. It is also in the youngest children, those below the age of 5 years, where mortality due to TB is the highest. So the risk of developing tuberculosis disease is the highest in young children, but important to note that this risk increases again during teenagehood and adolescence. But the risk of dying from TB is certainly the highest in the youngest children. And then the risk of TB infection is age-related, increases with age during childhood. The spectrum of TB disease observed in children is very much a function of age, with lymph node disease in the chest really predominating in younger children. And this is the type of TB which one should then be expecting and looking for on chest radiograph, if available. And whereas older children really tend to develop adult type disease, which is easier to diagnose using bacteriology and chest X-ray. It's also important to note that the youngest children are at the highest risk of developing disseminated TB, notably TB meningitis, a big killer. So the diagnostic tools and strategies should really consider the disease spectrum and the age of the child. So what are some of the challenges in diagnosis and reporting of childhood TB? Signs and symptoms overlap with other conditions, especially in young children. Few cases are confirmed. Pediatric TB is typically paucibacillary, so the gold standard culture is usually negative in the majority of children, more than 60%. It's challenging to obtain specimens, respiratory specimens in young children, and then lab capacity is often a challenge. There's also systematic underreporting of children, especially those often diagnosed clinically, and in many settings, the private sector does not report completely, and certainly not on pediatric TB. So what is the impact of COVID-19 thought to be on pediatric TB? As with adult TB, significant negative impact. And this is an example of the TB care cascade for children. And it's thought that, especially here, children presenting for care and diagnosing TB in children, that there's a massive and dramatic decline as a result of COVID-19. And this obviously would lead to fewer children being treated and excess mortality. In settings like South Africa, following COVID-related lockdown periods, we have seen a 50% decline in children routinely diagnosed with TB and started on treatment. And this is really alarming. So recovery strategies for TB in relation to COVID-19 should really specifically consider the needs of children, including getting children into healthcare services and appropriately evaluated for tuberculosis. I think it's important that we all acknowledge and embrace the fact that the vast majority of children, and especially young children, will and should be clinically diagnosed. The diagnosis of TB is a bit of a diagnostic puzzle with clinical aspects, symptoms, contact history, the chest X-ray playing a big part of the diagnosis, and TB bacteriology certainly adding an important part if positive and where available. But clinical diagnosis will remain the mainstay, and I wanted to just highlight the importance of clinical follow-up as an often neglected diagnostic tool. And here you see a child who's been initiated on TB treatment and with a very nice response in gaining weight. Chest X-ray remains a critically important tool to help make the clinical diagnosis in a child, and if used well, can really have a dramatic benefits. In this study of children living with HIV, the diagnostic accuracy or the sensitivity of chest X-ray was more than 70%. Chest X-ray quality may be variable. Chest X-ray is not always available, and there's certainly inter-reader variability. But there are exciting developments in terms of looking at increasing pediatric access to chest X-ray, improving the quality of reading, and also looking at computer-aided technology for reading. And these strategies should certainly be advanced. It's important to note that when an X-ray looks like this, so uncomplicated lymph node disease, that we can expect to find the TB bug by culture in about 30% of children. And this is the gold standard of diagnosis. And if a child's chest X-ray looks like this, disease is more severe, we're more likely to find the bug. But the vast majority of children will actually have a low yield of the organism. And therefore, tools like Expert and Expert Ultra, which might have a sensitivity of 75% compared to culture, will certainly aid in the diagnosis, but if negative, does not exclude the diagnosis of TB. And if 30% of children were to be culture positive, an Expert Ultra were to detect 75% of those, it still means that only 25% of children would be positive bacteriologically. There is certainly an advantage to the rapid detection and also to the ability to detect rifampicin resistance on Expert Ultra. And similarly, more child-friendly stool methods, such as sample collection methods, such as stool, also offer advantages above more invasive sampling, but certainly their sensitivity would be lower than in respiratory specimens, have all look like between 60 to 70%, and is not a magic bullet for the rapid increase in case detection of pediatric TB. Other less invasive tools like urinary lam, for example, Fujilam, also show promise, but again have lower than desired sensitivity in children and can certainly aid in the diagnosis, but a negative test does not exclude TB. So what are some of the strategies to really find the missing cases? I'm going to propose two and then perhaps just mention two additional strategies with time in mind. And the first is that I think it's important that we start thinking towards improving the evidence and the implementation of robust field studies to look at the clinical diagnosis and really looking at clinical algorithms more broadly. And secondly, that we improve on our current diagnostic tools and we think of how we should be evaluating these in the context of research. So firstly, diagnostic algorithms. I think it's important and encouraging to note, and as clinicians, we work in routine care using clinical algorithms. That's just how clinicians work. And this is a study looking at mostly HIV negative children and showed that the clinical evidence, so this is well-defined symptoms, contact history, identified 71% of all children confirmed with TB. And if we add an X-ray to these symptom and contact history, we find an algorithm that's more than 90% sensitive to detect TB. And also that it actually keeps sensitivity at a very high percentage, above 90% amongst the youngest children and those that are poorly nourished. So even if we do not have X-ray, that we can actually detect the vast majority of children with TB, and that X-ray certainly adds value. And there's these kinds of studies and field studies and also operational research that should be expanded going forward to ensure that children get access to a robust and reliable clinical diagnosis. Second, novel diagnostic tools such as biomarkers should obviously be further evaluated. Very exciting developments in this regard, but no tool is yet ready for prime time, and there's no true point of care test available yet. It's important that more research on these tools continue, and that investment continues to come up with more accurate and more sensitive tools that are truly designed to detect the spectrum of TB that we observe, and including in young children. These tools should look at sampling methods that are not sputum-based, specifically serum and blood and saliva, and should also evaluate these new diagnostic strategies in the context of clinical care, clinical algorithms, and also in the models of care, for example, centralized versus decentralized strategies. And these studies should actually not only look at diagnostic accuracy, but look at the impact of these diagnostic strategies on treatment initiation and outcomes in children, ideally. Lastly, I just wanted to mention 2 other important strategies in order to find the missing cases, and that is improving TB contact management in children. This will result in not only more prevalent TB cases in the households and other congregate settings identified, but also in the identification and prevention of additional cases in children. This is also an important public health strategy that has suffered very negatively in the context of COVID-19. And lastly, I would just like to note that in addition to improving diagnostic strategies, it's really critical that we look at improving recording and reporting of pediatric TB, so the ways in which we record and report, where we report from. We include hospitals as well as community-based clinics, and we make an effort to really include the private sector and pediatric TB recording going forward. And I'd like to thank all of you for your attention. Thanks.
Thank you so much, Annika, and thank you so much to all our great panelists as well. I really enjoyed all the talks, and there's just a few questions, so we're just gonna open up a roundtable with all our panelists, and if there are any questions, please send it through on the chat as well. The first one, Yogan had actually answered it on TextWave, but if he's around, I'll ask him as well. Somebody had asked thoughts about asymptomatic patients with regards to active case finding and how we can solve that gap. Yogan had basically stated that it is an issue and it's a really important one. It's similar to the issues for asymptomatic COVID-19. He described contact testing, retesting those with previous TB use of chest x-rays, and important for all these NTPs to focus on them. I also just wanted to ask him, I see him is back on the screen. If we look at WHO, they had stopped population-wide active case findings from about 1974 or so. The reason being that they had thought that smear positive cases weren't really showing us the path to significant TB disease and decreasing transmission. Do you think this is something that they're going to change in light of all our epidemiological data?
Uvi, thanks very much. Well, I certainly hope they would reconsider the decision taken a couple of decades ago. And I think it's important for high prevalence settings. If, for example, in the survey, TB prevalence survey that we just concluded in South Africa, we know that we are not finding TB in men, for example, and because men don't come to our facilities, etc. So, I think rather than doing it community-wide, and we tried that, Uvi, you might know, in South Africa with COVID, trying to going household to household into communities, looking for people with COVID symptoms, and it soon overwhelmed us, and we stopped doing it. And of course, we didn't have enough people to do it. We didn't have the tests to take into the communities, etc. And of course, it's more difficult with TB because you'll have to take the sputum, get it to a lab, etc. So, if you have a point of care test, I think it would be easier to do. But of course, we're not there yet. Thanks very much. Back over to you, Uvi.
Sure. Tuan will just ask a question now.
Thank you, Dr. Yogan. Then 2 questions to Dr. Morten. One is about an audience would like to know to what extent digital TB detection programs on different platforms or software are reliable. Another person asks for your opinion because he or she is working with Cat4TB, but it does not seem to work very well when they read the radiographic images, and the clinic seems to be better for screening. What is your opinion about that?
So, can you hear me? Is the sound working?
Yep.
Great. So there are at least there's at least 10 different AI softwares where about 7 of them are in commercial use. And it all depends on how this is being set up at the individual clinic in terms of the workflow. I think with proper setup, the workflow can be very seamless, and the AI result would be available automatically, either as sort of a standalone software or as part of the PACS software. So in terms of performance, in terms of accuracy, it's still early days, but what we have seen for the big review that was prepared for the WHO policy, it seems that whatever the humans can do in terms of diagnostic accuracy, the CAD softwares can deliver a similar performance. I don't know if that answers the question.
Yeah, that sounds good, Morten. I just wanted to jab in a bit. We look at what the UN HLM 2018 had said, where we're going to aim for our 2035 target, and 2025 we're going to try to get somewhere halfway between. We're a little bit shy of that. If I look at the way we're functioning within our own TB community, Morten, you're in diagnostics, Max, you're in doing therapeutic DST work, and you were talking about genome sequencing. Are we too siloed within our own TB community? If we can talk about active case findings, but how can we influence these national TB programs to change their policies if we continue as an academic community to remain so divided within ourselves?
I don't know, Max, do you want to start?
Yeah, I mean, that's a really excellent point, Uvi. You know, we're very siloed. There's a limited ability to impact policy, whether at the national level or at a regional or local level in terms of TB control. And you know, and furthermore, I think, you know, from the local and regional and national level, the research, they're sort of poorly able to sort of influence sometimes the research agenda that we researchers you know, pursue. And this is, again, from my perspective as a researcher, never mind, I think an activist or a public health official or a clinic doctor might have a different, you know, perspective again, but I think we'd all agree that we're all very siloed, and sort of paradoxically, I think we'd all like to work more closely together. So I think it is sort of really worthwhile to try to figure this out, and something that, you know, we've been talking about since I've gotten involved in TB over the last 20 years. This has been a recurrent conversation. So it really is a shame that we've not gotten further on breaking down these silos, and it maybe is something that needs to be sort of further addressed. I don't know if others have thoughts.
This is Annika. So I think, Uvi, that is an excellent point. I think just speaking from a pediatric perspective, especially young children below the age of 5, both from a policy and implementation and a research perspective, the most obvious way to integrate TB and the most obvious way to find cases and to treat them is actually through general child maternal health care services. Children do not present as a label with I might have potential tuberculosis. They do not present to TB services, but they present to child maternal health services, and an integrated approach to child and maternal health management has been advocated, you know, by WHO and others for many decades. So I'm thinking of the integration, for example, between PMDCT programs, child nutrition, immunization, and if we can integrate COVID-19 screening and testing into these services, there's no reason why TB should not continue to be strengthened into these services. This is where there are lots of missing cases, where there's an opportunity at every visit, every contact with the healthcare system, whether it's primary healthcare or hospital level, to ask about TB exposure, growth, look at immunization, you know, look at symptoms. And so that's kind of a no-brainer. And this is information that we know. This is already recommended. It just actually needs to be implemented more broadly. And there's great scope for integration of child lung health services and improving that within existing child maternal health care services. And you cannot actually have a siloed approach when dealing with young children. It just, this is not the way they present to health services. So I just wanted to remind everyone of the most obvious opportunity and I think responsibility to integrate healthcare both for prevention, diagnosis and treatment of TB and more broadly lung health. Thanks.
From my side, I think one of the biggest barriers we have is the sputum sample. And I think if we can replace the sputum, not necessarily with something that is as accurate as sputum, but is much more available, we will be able to get more of these missing cases in and have something that allows for more integrated testing. A sputum sample is not the same as a nasal swab. So that kind of is an inborn challenge with integrating COVID and TB testing.
Yeah.
No, definitely. I think you all have basically reinforced that we need to reinforce existing systems. And but I agree, Morten, getting rid of sputum and finding something a lot more efficient would be getting us all together a lot quicker. Tuan, do you have a question for the panelists as well?
Yeah, I think that integration of TB services or diagnosis and treatment into other health program is very important. However, from the presentation, the first presentation given by Dr. Yogan, about 60% of TB patients were asymptomatic. They were not diagnosed. They did not go to health clinic. Similar findings was found in many other countries, including Vietnam. We underdetect 50% of TB patients. So if they do not go to the hospital or clinics, they were not asked to produce sputum, not talking about whether they can produce sputum or not. How can we find them?
And I'm not sure who you're asking that question to, but I'll go. So clearly, for those cohorts of patients who have, whether it's symptomatic or asymptomatic TB, who are not coming to the health facilities, it's clear, and this is shown not just by TB, it's shown for most things that are gendered, that you have to go to where the patients are. And I think, a truly patient or person-centered healthcare service should not rely on people coming to a clinic, to a fixed facility. We have to go out to patients, to their homes. And I think the community health workers that many countries have are a very good opportunity to go into communities, to go into households, to look at who are contacts of known TB patients. We have to have very active case finding, and that means not only looking for TB in our health facilities, it means going to look for TB wherever TB is. And we said that about HIV almost 30 years ago, right? It's the exact same thing should apply to TB. But it seems like the TB community, and I'm including myself in there, learn these lessons rather late. We are always late to the party. The key, and COVID has shown us that yet again. But HIV showed us this, a couple of decades ago. So, we need to get the TB community, shake the community up and get us going and doing things that other people have already shown us work better. Thanks. Over to you.
Can I make a comment? I thought that was really striking statistic in that data you presented, Yogan, and it was really interesting to think about, particularly the role of the contribution of that asymptomatic 57% to transmission. And I think contact tracing, particularly in low and middle income countries, is not perhaps routinely always performed. And there have been modeling studies sort of showing, particularly, for example, in Thailand, that it is cost effective and effective. But beyond that, there's new research sort of in spatial and temporal modeling of transmission, suggesting that in places such as in South Africa, that sort of loci of transmission are sort of surprisingly durable. That is to say, a lot of the transmitted cases seem to center in certain areas, year in, year out. So I think beyond contact tracing, we can also think about deploying, teams to, to areas, that are sort of seem to be transmission hotspots, and that is another approach. But I agree with you. If people are not symptomatic, they're not coming into care, and in a way, a lot of what I'm focused on is diagnostics, and they're not going to be eligible for that simply because they're not in healthcare.
I just wanted to add one comment to the what Yogan made about contact management, and Max as well. So I think it's important when we do TB contact management, and even in high burden, low income settings, it remains an extremely effective tool in finding cases, but also finding cases earlier and preventing household transmission for prevalent TB. And we know that TPT prevents incident TB, and it's an opportunity to prevent incident TB. But most cases, actually, even if incident occurs soon after initial contact with exposed individuals, so a lot of transmissions already happened. So I think there's a missing opportunity to, again, emphasize the importance, if symptoms were to occur, to return to health services, because it's not just a once-off interaction with those exposed, for example, in the context of a household, but that there's education about TB symptoms and advising individuals to come back for testing and coming to services earlier. It's not a once-off, it's not a cross-sectional interaction. And then there's obviously the opportunity for finding TB cases earlier and preventing transmission, as well as offering TPT. So the implementation remains really, really poor, even amongst the most vulnerable individuals, including children below the age of 5. And we know that transmission happens outside the household as well, but this is a known unit of transmission where we can intervene, and we actually have an opportunity where we can really have an impact. So just wanted to comment on that opportunity of recalling, educating, so that individuals can present to services earlier, and the opportunity for education as a tool, as opposed to a single-off magic bullet as a diagnostic.
Okay. Thanks, Annika. It's so true what all of you guys are saying, and I don't know, I just find that some of my European friends always find that I'm doing exotic work with TB, and COVID really has humbled us at how much has been done so quickly with also droplet disease infection, and we have to jump on the train. It's just clearly evident. Annika, I just wanted to ask you, in terms of pediatric TB, what do you think about, Rob Wilkinson always fights with me, and he says he doesn't agree in the concept of incipient TB test. Do you believe that there's such a thing as a prognostic test, in the concept in children where we could pick up a spectrum of disease if we had to get that blood marker instead of a sputum sample? And just to overlap with Morten as well, do you think that we should not be so difficult with these WHO target product profiles if we had to look? It seems more like a thumbs up to me in pediatric TB, far so from adult TB. So I just want to know what your guys' thoughts are on that.
I would also love to hear Morten's thought about the question about incipient TB. I think we need to realize that in a young child or an immune compromised child or a malnourished child, there aren't very clear-cut and transition between disease states with a clear timeline allocated. That disease progression can happen really quickly, and progression to severe disease, including TB meningitis, can happen extremely quickly. In the context of a well child, stable child, and at follow-up, I think it's really useful to know which children are at risk of future disease progression, so we can potentially target preventive therapy strategies. But I think there's not always, to me, clinically, if you were to follow children up, the actual fine line between when exposure and infection and early disease and overt disease manifests. It's probably, if you were to follow children up on a daily, weekly basis, you would know that better in the context of natural history. So I think it's certainly, we need to look at the child's risk of progressing to disease, and based on the current tools that we have. And so with a test of infection or a marker that actually indicates infection and recent exposure and a high risk of progression, you actually need to treat based on that risk of disease progression and based on the risk of disease severity and the timeline in which that could happen. And that will always be different based on the patient you see in front of you. A 2-month-old baby is going to be different compared to an HIV negative 12-year-old child. So, I think that's from a clinical perspective. I certainly think it's important that we have tools that can indicate infection as well as early disease and response to treatment as tools to be able to kind of further our research agenda. But in the field and clinically and practically, I think especially the context of the child below the age of 5, where the most cases are still being missed and children are not being initiated on treatment, the risk of progressing to disease is really high. So I think it's really important that one actually initiates treatment based on what is known clinically and based on the available tools that one does have. Over to you, Morten.
Yes, so what you said for the children, I completely agree. Also in the adults, TB is a spectrum. When we do prevalence surveys, we find all of these abnormalities on chest x-rays. And when we then take a sputum from these actually are transmitting TB with pulmonary TB. They just don't feel any symptoms around it. But clearly we need to get a better grip of that population. We put face masks on people in the communities, and we actually also can take TB bacteria out of the aerosols there in people who are walking around in the street who are feeling completely well. So yes, we need something that can detect earlier before we actually have symptomatic disease. And there's been a lot of talk about these transcriptomic assays that can predict TB's incipient TB tests. And I think the Cortis trial that was published earlier this year clearly shows that the concept of incipient TB testing is feasible. However, whether these people need a 3HP, probably not. They probably need something that's closer to active TB treatment to be efficacious. So I think there's a lot of things we do not know. Another challenge in this subclinical incipient space is that the bacterial load is probably lower. So the performance or the availability of bacteria is going to be lower. It's going to be more difficult to detect them with an ultra-sensitive LAM test, for instance. So there's a lot of unknowns there as well.
And what do you think about the target product profiles? If we had COVID diagnostics so quickly, should we just be a little bit more lax right now?
I think we need to look at the target product profiles again. The triage TPPs were clearly developed for something like a biomarker and not for like a digital tool like a cough app or something like that. And the TPPs are back, they were made back in 2004, I think. So I think we need to look at what we've learned with COVID. We have to really say, okay, they managed to get several hundred diagnostics over the counter in the first 9 months of the COVID pandemic. Why does it have to take so long time to generate the evidence, to convince the WHO to do policy? Do we need to be as rigorous as we have been in the trialing? Do we need all of these follow-up visits to have a rock solid reference standard for our accuracy trialings? I think there's a lot of learnings to come from COVID, yeah, we can do better, definitely.
I would like to add to that in terms of the target product profiles, Ivy and Morten. I think there really is a need for rigorous, pragmatic implementation science around diagnostics and how they actually work in healthcare systems. And I was referring to pediatric TB diagnosis earlier, but for any person in front of you, health services and systems do think of algorithmic approaches. And so how do tests actually perform in the context of services, systems, with the people that are going to use them? How do they impact on the diagnosis and treatment initiation? But these tools do not stand on their own. So I think there's a real scope for very robust but pragmatic implementation studies to look at how these tools really perform in the context of healthcare services, rather than just focusing on their diagnostic accuracy. And there, we would really then want to look at impact at a larger level, and that's going to be, I think, far more useful than an individual diagnostic accuracy characteristic of a specific tool. Thanks.
I agree, and it's a stepwise approach. Of course, you need to understand what's the raw performance, but rapidly after that, you have to put it in the right context, definitely.
Great, thank you. Jen?
Yeah, I think it's great, it's exciting to listen to the discussion as well as to see so many tools presented by Morten. However, the cost is high for developing countries. Is there any possibility to reduce the cost of those tools for countries like Vietnam, for example? Anyone have any idea?
Yeah, so FIND is an organization who is supporting manufacturers and academics and others who are working in making diagnostic tests available in country at a more affordable price. So I can't speak on behalf of any of the manufacturers, but clearly, you know, the aim here is to make tests that are high quality and also affordable available in the countries, of course.
But Morten, you'll agree that some of these tests, which have been in the market for a while, because there's been no competition, are still very expensive. You know which one I mean, right? Without naming it.
Definitely, and we're working to change that, of course. I think that should also be evident from my presentation earlier. And I think there are coming some good alternatives in the pipeline.
Great. Well, thanks everybody. I wish we could keep all our panelists for the rest of the day. It's already reached 4:30. I will try my best to try to get through some of the questions that we missed to our panelists as well in the future. I just want to thank you all for an excellent session and thank our speakers for their riveting talks and really getting the conversation on eliminating TB and how we could really learn the lessons we've all learned as human beings for the last year to change the path for our TB patients and societies we serve. Just a reminder, this webinar will be on the website as well as will be sent as a pre-recorded towards all registrants available. This next series will be announced, the fourth and final one of this webinar series, and it'll be a roundtable discussion on how to actually mobilize to ending TB. So I hope we've given you all some tools and questions to gather for our next webinar. I thank you all for joining us. Wish you all a great rest of day and good health. And I hope to see you all smiling soon. Cheers. Thank you. Bye.
Thank you.
Thank you very much.